Harine. Then Hari. Okay. So, right. So what early deaths are here. So did you want the previous slide also? So this is the previous slide, which is of importance. And then, right. So when we talk about this golden hour and the platinum 10 minutes, that is the time period where you can do a difference, act fast and save lives. So we can prevent the early deaths or the second peak of trimodal deaths, right? What the studies have shown since like 1970s is within the first hour of injury, whatever the medical interventions patient receive will determine the outcome of the patient or the survival chance. So up to now, the mainstay of action is rapid transit to hospitals. That is the standard of care. Okay, rapid transit to hospital remains the standard of care up to this date, even in all these hi-fi centers. So the difference between our country and another country would be the trauma team. Most of the developed countries will have what is called a trauma team, which is comprised of these people. There's a team leader, an airway doctor, an airway assistant, another provider doctor, and 2 nurses. In our country, we wouldn't have all these roles allocated, but we would pretty much do the same thing. And we have all the other additional roles like scribe coordinator, transporters, technicians, radiographers, and all the special surgeons. So like in a major trauma, like a big motor traffic accident, in a developed country, about 15, 20 people come to the ED just to look after this one patient, right? So what are the trauma team pearls? You have leadership, clinical expertise, because now I said there's 1 hour to act, right? So you need to have expertise. You can't take a long time to determine what's wrong. You need to have good communication skills. You have to have mutual respect, because we are going to deal with a lot of categories of staff. You might even work with a team you are not familiar with, like paramedics. And then feedback and debriefing at the end, so that the whole team gets appreciation, and also they'll be more prepared for a next trauma. So in the handover, we have to mention a minimum of these 4 things. You have to talk about when you hand over a trauma victim. Now, if you are the house officer who in a peripheral kind of a hospital, say Marvanella Hospital, bringing a patient to Kandy Hospital, which is a common scenario. There's a more traffic accident in front of Marvanella Hospital. You got this patient to the Marvanella PCU. You are the accompanying surgical HO coming to Kandy. Minimum of things you must know is these things: the MIST, mechanism, injury, signs, and treatment. Treatment and travel, basically, how did you all bring the patient? That's called a MIST handover, right? So we always start with the primary survey. That is our ABCDE approach. In trauma, we call it primary survey. The difference between the normal medical ABCD and the trauma one is that with the airway, you have your C-spine precautions, right? Airway maintenance with restriction of cervical spine motion. Then breathing and ventilation, circulation with hemorrhage control. You must always remember the fact that it's not just circulation. You need to do something to control the bleeding. Then you have disability, then you have exposure, right? So managing the airway, look for foreign bodies, identify these facial injuries like facial or mandibular fractures, tracheal laryngeal fractures, other injuries that can cause airway obstruction. You can suction to clear blood and other secretions. And you need to, if there is upper airway obstruction, bypass that airway, and you have to create another airway, probably using a surgical front of neck access, that is a tracheostomy. If the GCS is less than 8, we consider the patients are not able to protect their airways. So you must insert a definitive airway, cuffed secured tube. Now, medically, sometimes you would have seen people with ICH and all who has like GCS of 3. Sometimes we leave them alone without intubating, but that is not applicable to trauma. Okay, right. In trauma, when we say when we manage airway, we always say keep your C-spine safe. Right. So for the to keep the C-spine safe, what we should do is we should apply a cervical collar that is mainly to communicate with everyone. Now you've got 25 people around the patient. Everyone must know that the patient needs neck protection. So that's why we put a collar in. If we are thinking of a true cervical spine injury, we have to go for a Philadelphia or Miami J collar. Right, not this ghosts and cardboard and soft collars that we use in our setup. But anyway, whatever we use is a communicate. It's a way of telling everyone, look, this guy's neck is needs to be protected. So maneuvers wise, what we would do is just the jaw thrust. We wouldn't do the head tilt or chin lift. Right? Okay. If we move on to breathing, we always look for problems in the chest cavity or the thoracic cavity that can result in immediate death. So if you've got, so the things that you examine are, look for jugular venous distension. If it does raised into thoracic pressure, your JVP will go up, right? Then the position of trachea, chest wall, you have a look at the chest wall to look for open pneumothoraces, flail segments, major trauma like major contusion marks, seatbelt marks and all that. You also have to inspect the neck with the chest and auscultation for added sounds and equal air entry to bilateral lung fields. So the injuries that significantly impair your ventilation are tension pneumothorax, massive hemothorax, open pneumothorax, and tracheobronchial injuries. Okay, these things are the most important breathing abnormalities after a trauma. There are another set of injuries. They are there, but they wouldn't cause immediate or early threat to life. That is like a simple pneumothorax, simple hemothorax, fractured, 1 or 2 fractured ribs. We pretty much wouldn't do anything about it. Flail segment, then pulmonary contusions. These things are important, but they wouldn't be a cause of death in the early phase. So what are we going to do? Oxygen for all injured patients. All trauma victims, regardless of their saturation, needs oxygen because they've got so many other things going wrong. We must ensure we give them the highest amount of oxygen carrying capacity. So oxygen for all. Then manage the airway. So now we were talking a little bit about the airway management beforehand also. So if the GCS is low, intubate. If the upper airway is completely obstructed, you can go for a surgical airway. If it is in between, if the airway is threatened, you can go for an intubation. Now you need to modify your techniques, right? Now, when you have C-spine protection, we call it manual inline stabilization of the cervical spine. One person holds the trauma victim's neck, the second person intubates. So to facilitate if you can't do your triple airway maneuvers, you are not going to get a good view of the larynx to intubate. So to facilitate that, there are some modifications to the instruments we use. So the commonest laryngoscopes that you all would have seen has the Macintosh blade or the normal curved blade. There's another blade called a hyperangulated blade, which looks like a J, which is more physiological. And then people use things like video laryngoscopes, CMAC blades, glidoscopes to increase the visibility of larynx when there is restricted neck movements. Sometimes people even use bronchoscopy to intubate these guys, right? Okay, then the next important part is decompressing the chest. So what we can do is, if a trauma patient is in a peri-airway situation, we always assume, fine, this guy may be having tension pneumothorax. So we go for a massive hemothorax. So we go for a finger thoracostomy. I'll show you how it's done later in the presentation. We need to convert it into a IC tube. Finally, ventilation. Managing breathing, you have to think of ventilation as well. So in trauma, this is the most, not the most important, but one of the very significant things, circulation. So hemorrhage is the leading cause of preventable death after injury. So before you now, almost always, pretty much 99% of the time, if a trauma victim is hypotensive, we always think this guy is bleeding. One thing you need to exclude is tension pneumothorax. That's why we go for an early finger thoracostomy or a decompression of the chest wall. Right? So clinical observations are now how to identify this blood loss. The things you look for are your level of consciousness, your skin perfusion, and your pulse. So if the blood now, in any type of shock, our body is programmed to preserve vital organ perfusion. So if you're so hypotensive that you're confused because of that, that tells us this is critically hypovolemia because your cerebral perfusion is now impaired. Then when you look at a patient, if the fellow is pink and nice looking, it's unlikely to be critical hypovolemia because you won't be able to perfuse your skin if there is a massive hypovolemia. The body will shut it down and the body will divert the blood to your vital organs. Skin is not a vital organ. So if, and vice versa, if the skin looks ashen and gray and clammy, that suggests critical hypovolemia. And the pulse rate, a rapid steady pulse, is typically hypovolemia until proven otherwise. Always check your central pulse, carotids or femorals, bilaterally. Look for the quality, rate, and the regularity and volume as well. So in a trauma victim, if you can't get a central pulse, that means this fellow needs resuscitation. So bleeding could be external or internal. If there is any external bleeding, you must try and control it by direct manual pressure. And if that is not successful, only we use a tourniquet. We don't use tourniquets anymore. We try and use the direct manual pressure, failing which we would go for tourniquets. Then other type of bleeding is your internal bleeding. You can bleed into the cavities and also in the floor. So all the external bleeding would be on the floor. Other bleeding would be, your internal bleeding would be in your cavities like your chest, abdomen, retroperitoneum, pelvis, and your long bones. So again, how to identify? You use your physical exam characteristics. You can also have additions like imaging. Imaging, that means X-ray pelvis, X-ray chest, focused abdominal sonography in trauma, then diagnostic peritoneal lavage. Right? This is how you identify bleeding. So basically, this is a summary of your E-fast. We add the E or the extended fast because we now look at the chest cavity as well. Historically, it used to be just the 4 quadrants where you look at the right hypochondrium, left hypochondrium, then you look at the subcostal or the cardiac view, and then you had a look at the pelvis. Now, of course, we do all these. We look at the subcostal view. We look at the IVC with that. We look at the right hypochondrium, look at the Morrison's pouch, because that is the most dependent part of your abdomen in the supine position. That's where initially you would see fluid, right? So the first bit to see free fluid is here, between the liver and the kidney. You see here. Okay, right. Then you have your left hypochondrium, then here pelvis. Pelvis, you take 2 views, sagittal and the transverse. And finally, we look at the chest cavity. This shadow black bit is your rib. This is your pleura. If the pleura is active, walking like a school of ants, that is fine. If the pleura is not moving, it tells us that there is something in between the visceral and the parietal pleura. It's likely to be a pneumothorax. Okay, there are a few other ultrasound features that we use as well. So now there are 3 modalities we are discussing here. Now we said imaging, and also now I'm imaging, and we spoke about the fast. And then I said you can identify bleeding using a DPL or diagnostic peritoneal lavage. And also what we can do is a trauma CT or a pan scan, it's called. Now, that is the gold standard method of imaging a trauma victim. Actually, that's the gold standard. So that is what most of the other countries use. We are slowly going there. So you must know the advantages, disadvantages, and indications for these three modalities. Now, CT scans are very expensive, and you need to move your patient from your emergency department. So it's not applicable to hemodynamically unstable patients. Your patient's hemodynamics needs to be stable for the patient to go for the CT. But DPL and FAST both can happen in the emergency department. So especially this FAST is a repeatable, non-invasive, low-cost modality of imaging. It can like if a FAST is positive, you need early intervention, early operative intervention. The only drawback would be it's not great when you have a lot of air. If the bowels are distended or if there is free peritoneal air, ultrasonography is not good. It's not great. And if the patient is very fat, it's not great. Apart from that, it's the best modality that is available to us at present time. This might change and we might move on to doing trauma series CT scans for all patients, all polytrauma patients. Right, so what's the problem in your circulation? That's the trauma-induced coagulopathy. So you have your trauma, you lose blood. Because of that blood loss, you go into hypovolemia. Apart from that, you go into what is called the trauma coagulopathy, right? So it's a long process over the next course of life. It starts at the time of the trauma, but progresses over the third phase or during a third phase of trauma management also. And then these processes are all they all get involved, right? So mainly the things that you need to remember are, if your trauma victim is in shock, these are the actions you must do. Decompress the chest, stabilize the pelvis, splint the extremities that look abnormal and bleed. Then you might need some surgery, like you can perform your imaging or your FAST. If it is positive, you go for surgical interventions. And you might even ask for your interventional radiology colleagues to come in and help you, especially in things like pelvic fractures, where you have bleeding into the pelvis, can easily tie or like embolize the culprit vessel. And also you need orthopedic interventions again for things like open book pelvic fractures, right? So what do we do? So that these things are your definitive things. So what do? We do these things. As the first line people, we would get the IV access. We'll try and put 2 wide bore cannula. If we can't get a cannula, we would put an IO line, a central venous line, or a venous cut down. Then we take bloods for the basic bloods. Basic bloods meaning count, your electrolytes, your renal functions. And depending on the injury, other things are also important. If you're having a liver laceration, your LFTs are important. If you're thinking of crush syndrome, where you have a lot of muscles crushed, the patient is likely to go into rhabdomyolysis. So you need your CKMB. Then if they're bleeding horrendously, you need your coagulation profile and your thromboelastometry, right? So for all major trauma patients, you have to have your blood grouping and cross match. If the patient is a female of childbearing age, they must have a pregnancy test. And pretty much all the patients, we do a blood gas level to look at the hemoglobin, the PCV to look for hemoconcentration, the lactate level to assess the perfusion of the tissues, the base excess so that you can grade your hypovolemic shock. So VBGs, the advantage of VBGs, most of the emergency departments, at least the big ones in the country, they have a VBG machine in the department like the one at Peradeniya. Right, so the results are immediately available. So what to give these patients? Now we feel the first instinct is that the patient is hypovolemic, give fluids, right? But in trauma, we don't just give fluids. So whatever fluid we give has to be warmed because the patient's trauma victims go into hypovolemia and hypothermia, which both result in the problems of coagulation. So all contribute to death. So hypovolemia contributes to death, hypothermia contributes to death, coagulopathy contributes to death. So all fluids needs to be warmed. We have a restrictive fluid approach. So we use only a little bit of crystalloids. We use about a liter. What they say is more than 1.5 liters of crystalloid fluids is associated with increased mortality. So we go for early blood and blood products. That the term we use, how we describe it is hemostatic resuscitation. So clot forming resuscitation. So we give them 1:1:1 ratio of packed red cells, FFP, and platelets. That prevents your trauma-induced coagulopathy. And that is why for polytrauma patients in hypovolemic shock, you need to activate the massive transfusion protocol. Massive transfusion protocol, it's just like a one phone call to the blood bank kind of a thing. They prepare boxes to meet this 1:1:1 ratio. And when we give the fluids, when we fluid resuscitate trauma victims, we do it using a principle called permissive hypertension. We allow a hypertension. Okay. So we just want enough blood pressure to maintain vital organ perfusion. Because if you increase their blood pressure, the tiny clots, the microclots that form, which helps to stop bleeding, gets dislodged. Right? So we just maintain a mean arterial pressure above 65, and we are happy with that. We don't want systolic blood pressures to go up above 100. One other more important the drug with mortality benefit is your tranexamic acid. So if you have a trauma victim who presents to you within 3 hours of the injury, we give them 1 gram of IV tranexamic acid, followed by 1 gram over 8 hours infusion for the first 24 hours. So we said hemorrhage is the cause in 99% of the time. There are other causes. So there is an element called non-hemorrhagic shock in trauma. These shocks are your cardiogenic shock, obstructive shock like tension pneumothorax, neurogenic shock when you have a high spinal lesion, and also if the presentation is quite delayed, they can even be in septic shock. That is not very applicable in trauma. So cardiogenic shock is caused by blunt cardiac injury, cardiac tamponade, air embolus, and rarely even due to MIs. Tension pneumothorax, of course, you understand it by itself. The pressure in the thoracic cavity goes up, so you can't pump beyond that pressure. So neurogenic shock, when you have a high spinal lesion, you lose your autonomic control. So disinhibition, autonomic disinhibition. When you have a high spinal lesion, you go into autonomic instability, right? So you have a very much peripherally dilated patient. They will have a bradycardia and hypertension. Okay. Now, don't confuse yourself regarding spinal shock, because spinal shock is not a form of low blood pressure. When you have a spinal injury, in between your spinal segments, there are interconnecting neurons. When you have an injury to the spinal cord, these interneurons go into shock, or in other words, they stop working. So you lose your reflex. You pretty much lose your neurological functions. That is called spinal shock, right? It's not neurogenic shock. Neurogenic shock is a form of low blood pressure, resulting due to the autonomic instability because you have a very high spinal lesion. A spinal lesion quite high, pretty much in your cervical spine, upper cervical spinal injury. Right. So hemorrhagic shock, we have different classes, and we use different parameters to identify these classes, like your heart rate, blood pressure, pulse pressure, respiratory rate, urine output, GCS, base deficit. So that tells us how much of blood is lost, or the percentage estimated blood loss, also whether you need to give the patient blood or not. So then there are 3 groups of people. Some patients are rapid responders, that's great. Some are transient respondents, not so good. And if there is minimal or no response to initial fluid prescription, that's bad. That's your circulation, right? Then we move on to disability. So the things we look for in the disability is your level of consciousness, the GCS, as well as things like hypoglycemia, alcohol, narcotics, other drugs. Now, the patient could be unconscious purely because the fellow was high on speed or something, like taken drugs, okay? Then you look for the pupillary size, pupillary reaction, any lateralizing signs, and also if you can establish the spinal cord level. Now, the supportive things that we use to manage, to assess disability, if you have a gentleman with paradoxical breathing, with no other injuries, but fallen from height, fellow complains of a neck pain, we have to think of the high spinal lesion, right? The patient is only breathing because their diaphragm is moving. They have a high spinal injury, and their chest wall innervation is lost, but the diaphragm is supplied by your C345. The injury is below that level. Your diaphragm movement is preserved, but the chest wall is not moving, resulting in paradoxical breathing, something like that. Okay, right. This is the correct way of assessing Glasgow Coma Scale. So it's freely available on the internet. Just have a look. What are the sites for physical? It tells you exactly what are the commands to give, how to do the physical stimulation, how to read it, how to interpret the responses the patient has. So have a look at this Glasgow Coma Scale. Do it this way. Or now it's been more than 40 years since Glasgow Coma Scale was described. I think it was described in 2008. 40 years for 2018. So long time. Okay. So you must know the correct way of doing this. Then the final bit of your primary survey is your exposure. You have to completely undress your patient, and after the examination, cover the person with warm blankets to prevent hypothermia. You can even use things like bear huggers to keep the patient warm, and warm fluids. Fluids generally we select a level of 39 centigrades. So depending on the mechanism, now I said when you hand over a patient, you have to do a missed handover, and the first bit of the missed M is mechanism. So there are injury patterns associated with different mechanisms of injuries. Okay. For blunt trauma as well as your penetrating trauma, you have different patterns of injury, right? So what is secondary? Now that is primary survey. Then when you have what is secondary surveys, you do a thorough head-to-toe examination and identify all the other missed things. Primary surveys focused on identifying life-threatening injuries. So head and neck trauma we are not going to deal today. So, but I'll have to say a word about the cervical spine. Now, at the beginning also I said a tiny bit. Now, if you have a patient who's got head trauma as well as chest trauma, we assume the neck is also traumatized. Okay. So we assume, because the neck is between the head and the chest now. So if there is head trauma and chest trauma, invariably we think the fellow has a neck injury as well. But if it is not the case, if you have a minor kind of injury, like a falling from height, there are 2 systems to use to assess the need for cervical spine imaging. Okay, one is called Canadian C-spine rule. Other one is called the nexus criteria. So if any of the nexus criteria is positive, or like answer is no, you have to image. In the Canadian C-spine rule also same. So you have this algorithm, you just go through that and you can decide whether the patient's neck can be clinically cleared, or whether the patient needs an imaging method to clear the C-spine. Okay, so all trauma patients get some sort of a collar that tells the treating team the C-spine is not clear. Then if it is likely to be a negative neck finding, negative for C-spine injury, you can go through these two sets of criteria and decide to clinically clear the C-spine or not. Okay, again, easily available in the internet. So you can just type Nexus criteria or CCR, Canadian C-spine rules, it will be there. Okay. Then we move on to thoracic trauma. So the major thoracic injuries we have already mentioned: tension pneumothorax, open pneumothorax, and a massive hemothorax. Massive hemothorax is when you have more than 1,500 ml of blood in one side of the chest. There are other injuries, not the major ones, but there are other injuries like simple hemothorax, pleural segments, pulmonary contusions, blunt cardiac injuries, traumatic aortic disruption, traumatic diaphragmatic injury, blunt esophageal ruptures. These are all thoracic trauma. What do you do? So if the patient is having low blood pressure or is in shock, we do this, right? So this patient is lying down here. We are using the same safe triangle that we use to insert an IC tube. But this is just a finger thoracostomy. Okay. Landmarks are all same. We would just convert. Now we are assuming the patient has a tension pneumothorax. We are converting it into a open pneumothorax basically. You release the tension by putting a skin incision, then blunt dissection up to the pleura. Then you open, like you go through your chest wall and open into your pleural space. That would release the pressure in the pleural space, right? For trauma resuscitation, we do bilateral finger thoracostomies. These needs to be converted to intercostal tubes late. This is only for resuscitation, right? So if the patient already has an open pneumothorax, we do this dressing. This is called the Asherman's plaster. We apply tape only on 3 sides. Now, this will act now. The problem of an open pneumothorax is it will accumulate air with each breath because it acts as a one-way valve, right? When you put this 3-sided taped dressing, during breathing, the dressing gets sucked into the wound, air doesn't enter. During expiration, air will come out through the free side. This is called an Asherman's plaster, right? So next most important thing is how are you going to differentiate these two life-threatening things? So it's easy. Both will, so tension pneumothorax, when you compare tension pneumothorax with a massive hemothorax, both will not have breath sounds. Pneumo will be hyperresonant on percussion. Hemo will be dull on percussion. And trachea, even I feel, but even though they say midline in for massive hemothorax, trachea could be deviated in both. Neck veins, distended in tension pneumothorax because of the pressure in the thoracic cavity. And chest movements, the tension pneumo chest would be expanded and immobile. It has filled to its maximum level, right? So expanded and immobile. So that is the thoracic trauma. Basically, for resuscitative methods, what you have to remember is your finger thoracostomy, Asherman's plaster, and how to put an IC tube. That's a skill now. Beyond that level, specialized surgeons will look after. Then we have abdominal trauma. So we have blunt and penetrating injuries. With the penetrating injuries, you have your stabs and your gunshots, right? So blunt trauma is associated with solid organ damage and small bowel perforations. Stabs could do anything depending on the site. Same for gunshot wounds. So important things here are suspicion. Now, if the patient is was a victim in the motor vehicle accident, if you have things like seat belt marks, contusions, abdominal wall contusions, that tells us indirectly that there could be an intra-abdominal injury. Okay, so most of the time abdominal trauma results in bleeding. So we have already discussed how to manage the bleeding part of it. Right, then pelvic trauma. So abdomen and pelvis pretty much go together. Now, if your patient who had a trauma has an unexplained hypotension, you look at the patient, you can't see anything on the chest, can't see anything on the abdomen, your fast scan is negative. That hypotension may be the initial only indicator of a major pelvic disruption. So what we have to do is, if you're thinking a patient has a pelvic fracture with hypotension, no other source of bleeding, you have to say this pelvic fracture is unstable, mechanically unstable pelvic fracture. What can we do? We can apply a pelvic bind. Now, most of the other countries would have prefabricated pelvic binders. You just have to pass it under the patient's bottom and tie the laces or put a Velcro. But in our country, because we are a bit of a limited resource part of a country, we would use a bed sheet. We would pass a sheet under the patient's buttock, and at the level of the greater trochanterus, we would tie a knot. We would bring it up, and the two sides of the bed sheet we would cross just above the pubic symphysis, right? And we put a knot there. The idea is to close an open book pelvic fracture or bring the fractured pieces together. So you need a considerable force when you apply a pelvic bind. But a correctly applied pelvic binder is a life-saving intervention. Associated with pelvic trauma, there are other things that we look for, that is the ruptured urethra. So if the patient has blood at the penile meatus or a scrotal hematoma, there is a discrepancy of limb length, if there is a rotational deformity of leg without an obvious fracture, you have to think of ruptured urethra. Okay, right. Now, I took abdomen and pelvis together because that's sort of a continuum. Okay, so there are some specific indications for an immediate laparotomy in trauma victims. So if any patient with blunt abdominal trauma has hypotension, has a positive fast scan, or clinical evidence of intraperitoneal bleeding like a positive TPA, without another source of bleeding, that tells us this bleeding is in the tummy. So that fellow needs to go to the operating theatre and have his belly opened. Then hypotension with an abdominal wound that penetrates the anterior fascia. So you have a stab wound. Sometimes you can have superficial cuts. Even stabs, you can have superficial cuts. But if the penetrating abdominal injury has penetrated through the anterior fascia, that patient needs to have a laparotomy. Gunshot wounds that have traversed the peritoneal cavity, you must open and see. Evisceration, you don't need any explanation. Evisceration is things have come out, right? Your gut is outside the abdominal wall. So bleeding from stomach, rectum, or GU tract following penetrating trauma, you have to open. Any evidence of peritonitis, you have to open. Any free air, retroperitoneal air, or rupture of hemidiaphragm, patient needs a laparotomy. Now I said no, contrast enhanced pan CT scan is the gold standard of trauma imaging. So if that is positive for any ruptured GI, intraperitoneal, bladder injuries, renal pelvic injuries, or severe visceral parenchymal injuries, those patients also need a laparotomy. So when we say PAN scan, when we say gold standard mode of imaging is contrast enhanced CT scan, we mean a head to toe CT. What in a PAN scan, what we do is brain, C-spine, chest, abdomen, pelvis, and your limbs as appropriate. If you are thinking of any long bone damage or vascular damage in the lower limbs, the PAN scan would be a whole body from top to toe. And it's always a contrast enhanced scan. That's why with the basic investigations, we always look at the serum creatinine level. Then finally, we have extremity trauma. The potentially life-threatening extremity injuries are injuries that include the major arterial hemorrhage like a femoral or a pelvic arterial injury. Bilateral femoral fractures, because one femur can bleed up to 1.5 liters. So both sides fractured means you lose about 3 liters, which is what? From your 5 liters of fluid, that's quite a lot. Then crush syndrome and acute compartment syndrome. Okay, crush syndrome is when you have a lot of contused muscle. You release myoglobin, right? Crushed muscles release myoglobin. Because of the hypermyoglobinemia in the blood, you have a lot of issues like renal failure. It's the worst rhabdomyolysis, worst end of the rhabdomyolysis. Then acute compartment syndrome can happen when you have a closed compartment, like your skin is intact, but there is a fracture underneath associated with the vascular damage. You are bleeding, and it gets accumulated in your limb compartments, resulting in acute compartment syndrome. Okay, right. Now, what are we going to do if you have a part amputated? During trauma, your hand is cut off or your legs are cut off. What can we do? What we should do is first thoroughly wash the amputated part in isotonic solution. Isotonic solution is the Ringer's lactate. The best one would be Ringer's lactate. If not available, you can use Hartmann solution. Then wrap it in moist, sterile gauze. Then wrap the part in a similarly moistened, sterile tub. After that, you place it in a plastic bag. Once you have that amputated thing washed, cleaned, washed, wrapped in moisturized gauze and towel, put inside a plastic bag, you transport that inside a cooling chest with crushed ice. And transport it with the patient to your trauma center. Now you have to be always careful not to place the amputated parts directly on ice. That will cause cell death. You can't reimplant those. And also we don't use water or hypotonic solutions because that will again cause cell death. And our idea is to preserve the viability of cells until it reaches the hospital. Okay, right. Now the polytrauma victim. Now we know a lot about trauma, right? We've spoken quite a lot about trauma, starting from the airway, starting from your primary survey, the likely injuries that you can have, a little bit of about management of the trauma victim. Now, what is a polytrauma victim? That is somebody who has had a big trauma, and because of the trauma, he has one or more major organ involved. More than one system is involved. Like it's not just a head injury, not just a chest injury, but the fellow has chest, abdomen together injury. Right? These victims needs to be managed in an organized manner. The best approach is a team approach. That's why I said the pearls of clinical team and the composition of clinical team at the beginning of the presentation, right? So always a team approach, and it's best if you can pre-inform the hospital, right? That's how it happens in other countries. There are paramedics who go to the scene. There are retrieval doctors who go to the scene. They look at the patient. They like extricate. Now, if the patient is stuck inside a vehicle, they would cut the vehicle open, extricate him, do whatever they can, or like stabilize the patient, put the splints, manage the airway, start the high hemostatic resuscitation, because trauma retrieval teams always carry O negative blood with them. They do all that, and they would do a phone call to the receiving end, and they would say, we have an approximately 30-year-old male who was in a road traffic accident, driving at 100 kilometers per hour, head-on collision with another vehicle. Other vehicle driver is dead. This guy was stuck inside the vehicle for 1 hour before we could take him out. After coming out, he's got head injuries. He's now intubated. We have done these things. We'll be at your institute in 5 minutes or 10 minutes or whatever. That is the trauma call. Right? Once you get that call, can we manage this person by ourselves? We can't, right? As emergency doctors, what we would do is we would call for help. We would activate what is called a trauma code, right? So we do all that. We do all that preparation to do the maximum for the patient during the golden hour, right? So once the patient arrives, now in the trauma code, we call all the people that is likely to be involved. We call and warn them. Hey guys, we have a patient like this coming to the emergency department. So the surgeons can finish up whatever the surgery they were doing. They can vacate the theater. The blood bank can get ready with bloods. And say if an orthopedic surgeon is needed, we can just inform them. They can also finish up what they were doing and come to the A&E to act within the golden hour. So we do a primary survey. Always remember A with C is fine, C with hemorrhage control. Okay. Then we do what is called damage controlled resuscitation. There are 3 elements there. Hemostatic resuscitation, which I have already described. Permissive hypotension, which I have already described. And the third element of damage control resuscitation is damage control surgery. Okay. So that is pretty much, surgeons get involved early. They do a physiological closure to the patient. They would pack the liver if it is lacerated, do a splenectomy if it is crushed. If there is any gut damage, you would just divert it out, put a colostomy, and leave the abdomen open. It's a short surgery, like 45 to 1 hour kind of a surgery, and the patient goes into the ICU for stabilization. The surgeons will get involved later for anatomical closures, right? We would do a massive transfusion protocol. Now we have discussed a little bit about why it's needed, the trauma coagulopathy and all that. And always remember, no unstable patient should leave your A&E for imaging. Imaging is only if the patient has stable parameters. Right? And one other important thing is preserve forensic evidence. You can't just, if it's a gunshot wound, you can't just throw away the bullet pieces. You have to preserve the ammunition and all, you have to preserve them. And manage the patient's pain. Even if the patient is unconscious, they say they can still feel the pain. So manage the pain, and don't forget their family, because it's, for us, it's just the patient. For the family, it will be their father or their son. So always remember the family as well. Right? So in treating the trauma patient, treat the greatest threat to life first. Never allow lack of definitive diagnosis to impede the application of an indicated treatment. A detailed history is not essential to begin the evaluation of a patient with acute injuries. Even if the patient is unconscious, we have no history whatsoever, you can still treat the patient using your primary, secondary surveys and adjuncts to your clinical assessment. Okay. 5 minutes. So if the patient has, if your patient is in cardiac arrest, what are we going to do? So we have to start resuscitation. If the patient is in cardiac arrest, your trauma victim is in cardiac arrest, you start resuscitation. And if you don't have, you usually follow your normal thing, like you maintain your airway, start cardiac massage, 100% oxygen, get IV access, use your adrenaline if the patient is in a PEA, like non-shockable rhythm. Then concurrent to your resuscitative methods, we do bilateral chest decompression using finger thoracostomy, right? Then, if that is also not helping with return of spontaneous circulation, ROSC is return of spontaneous circulation, we can actually do a anterolateral or clamshell thoracotomy and vertical pericardiotomy. That is to release any cardiac tamponade. Okay. If there is cardiac tamponade or cardiac injury, you control that. A cardiothoracic surgeon has to get involved. Okay. If there is no cardiac injury, if it is just hypovolemia, you can use clamps. Okay. You can use clamps on the abdomen, you can use a clamp on the aorta, on the thorax, you can use a clamp on the pulmonary pedicles at the mediastinal vessels, right? You continue your resuscitation up to that level. If the patient is still in cardiac arrest, after now here on your left side, you could see your time gaps as well. So we are not going to resuscitate these patients for a long time. All of these things generally happen within the first 15 to 20 minutes. The only exception is if the patient is severely hypothermic. If they are hypothermic, we try and bring the temperature to level of 34 before we give up. But we do all that, and at 30 minutes also, if the patient has no return of spontaneous circulation, we stop there. We don't go for prolonged resuscitation in trauma victims, because we know in the first few slides I showed you that early deaths, early unpreventable deaths are the highest group. Okay, right. So these are the retrieval services that get involved in the primary or initial phases of your trauma management. You have your road ambulances. What we have is this. Our paramedics are not like they're not trained to that level of these guys here. These guys, especially this guy, he's a trauma director who could pretty much do anything. Like they could even do a pericardial tamponade release on the field kind of a thing. They have, other countries have helicopter. This is also one of those. So they have helicopter retrieval systems where they could do all fancy stuff, underwater rescues, up in the mountains, they can do rescues and all that. But we have this, it will also progress to this level at one day. What you have to remember is there's very cramped space inside. This is an inside of an ambulance. This is the inside of a air ambulance or a helicopter. So you have pretty much no space to act inside these vehicles. Whatever you do on the scene, on the field. You stabilize the fellow and scoop and run to the nearest hospital to do the rest within the golden hour, right? So these guys are the true heroes of a trauma management, okay? Right, the final bit of the lecture is ethical aspects. So you don't need consent to treat life-threatening injuries. Even if the patient is unidentified, you can still treat them. Now, trauma victims, we said you need to take off all the clothes and have a look at them. So remember their privacy. If it was you coming to the Peradeniya A&E, and if I take all your clothes off in front of your colleagues, your friends, you wouldn't feel that comfortable. Same for the patients. So always remember their privacy. Then when you disclose things about the patient, make sure you tell the right person, right? You have a male person, one lady can come and say, this is my husband, what's wrong? 15 minutes later, another lady comes up and says, no, this is my husband, what's wrong? Right? So you have to always make sure who you talk to, okay? And some people have things called advanced care directives. These things are also coming into play in our system as well. Now, just like in Peradeniya, we do liver transplants now. So always, if you can't save a patient, try and save somebody else. It's called the GIVE protocol. So if you can't save your trauma victim, the trauma victim's young fellows have good organs. Those organs can keep somebody else alive, like your kidney transplant teams, liver transplant teams. They're happy to use these patients if they're happy to donate. So you have to have a chat about that as well with the family members if it's an unsurvivable injury. Okay. Then survivors of an accident, say there were 2 people in the car, husband is dead, the wife survives. So be very gentle when you talk to them. So there's a thing called survivor's guilt. So those things also come into play when you practice, right? And always remember the family. For us, it's just another patient. For them, it's one of their loved ones. Okay, so yeah, that is the ethical aspect of trauma. So do you all have any questions? If you don't have questions, I can quickly take you through 5 slides, but we are almost on time. So if you don't have any questions, I'm just going to quickly go through the next few slides. So what can you see in this picture? This X-ray, it's a supine X-ray of a trauma victim. What can you see? What's the abnormality? There's another lecture at 2:30, so you need to be fast. Can anyone comment? Can't comment. Can you see what's wrong here? There isn't anything. Right. You all go through and see what's wrong, right? If you all are not talking, we can't help it. What's wrong here? What is wrong here? What's wrong there? And the final one is here. So let's really go through what's wrong. I'm available in the A&E at Peradeniya, so you could come and have a chat to me later, because we need to finish on time, right? Tension pneumothorax in the first one, no. So the first one. This is a flyer segment. You have more than 3 ribs fractured in more than 2 places. That's a flyer segment. This is a diaphragmatic perforation. You can see bowel loops in the thoracic cavity. It's a bowel diaphragmatic perforation. This is a positive fast. This is the right upper quadrant view. This is the Morrison's pouch with a black fluid thingy between the liver and the kidney. So it's a positive fast. Open book pelvic fracture. This is a C-spine injury, odontoid fracture there. And this is a Jefferson's fracture. So just have a look what it is. This is bilateral pedicle fracture. Okay. Right. Thank you. And you should be going for your next lecture soon. Okay.
Thank you.
All right. Thank you. Bye.